Hello and welcome everyone, and thank you very much for all my lovely and dear colleagues. They are attending. Yeah, hi, my friends who are attending for the first time. I'm excited to, and thank you very much for attending today. And for my friends who are even listening to the record, you also are welcomed and thank you for listening to our record. Look, my dear friends, so we have a good chance today to go through the maternal infections, okay? And we will discuss some tricky point and some tricky questions, some common questions from the exams as well that will be discussed here today. And hopefully that will help you in your final revision and in your preparation for the part 2 exam. So my dear champions, let's see, okay, what are the point that we need to cover and that we need to discuss today. So I will show you here, okay, the very first question of the discussion, and let's see. The question says that we have a 23-year-old woman. She presented with rupture of the membrane, okay, and this is at the 27 weeks of gestation. The woman was found to have group B Streptococcus bacteriuria at booking, okay? All maternal observations are normal and there is no uterine contractions. The cervix is 2 cm long and closed with clear liquor draining. Fetal heart rate is 142, and if spontaneous labor does not ensure, delivery should be offered after, okay? So, dear friends, what are you going to do for this lady in labor? And she had history of group B Streptococcus bacteriuria. So he wanted to reassure you that there is no problems, okay, in the observation, but look to the gestational age. What is the gestational age here? Gestational age here is the 27 weeks. Okay, so we all know the rule of the 34, correct? So what we do before the 34 and what we do after 34. Yes, we need to clear the concept. This is the most important thing, okay? So the concept here is that this lady below 34 weeks, this is when the risk of prematurity outweighs the risk of infections, correct? Okay, so what I will do is I will do expectant management with antibiotics as well. So I will wait, no induction of labor. I will give antibiotic, right? Why? Because she's preterm and below 34 weeks. Correct? Correct. And then after that, okay, I will do at the PPROM guideline, very nice guideline of the preterm labor and the premature rupture of membrane. What is the recommendation? The recommendation that I will do continuous observation, including that I will repeat the C-reactive protein and the total count of the white blood cells in context of the clinical examination as well, because I don't want this woman to go through infection unnoticed, correct? So she is not in established labor, so no need for the magnesium sulfate. My friends who answered D, okay? Please forget, if the patient is not in established labor, there is no rule for the magnesium sulfate. The patient not in established labor, so the type of antibiotic I will give is the only oral antibiotic. Clear, my friends? So here, what is the answer? Among these choices, what I have? I only have the 10 days of the course of the erythromycin. Okay, and the guideline says that 10 days, whatever is sooner, correct? Yeah. Okay, I hope that everyone, okay, already have noticed this. Okay, great. So now we will see the next question. Yes, Dr. Rashmi, my dear. So this is again in the GTG of the prevention of preterm, the GBS disease in the neonate. It says that based on the studies, they found that the risk of prematurity outweighed the risk of infection. So for the infection, we give the antibiotic, okay, and we will do the observation, and this will be a close observation. Whenever you think that there is any signs of labor, then she can deliver, or there is any signs of infection, also you will deliver. Okay, dears? So here, my dear friend, yes, for a lady who have 27, she can take steroid. Steroid is not contraindicated, but among the options that I have, okay, I have the option of a corticosteroid. Is that the most important one here? In the case of group B, Streptococcus carrier and bacteriuria? No, okay? So what I need to do here, this is, I will ensure that she receives the antibiotic. If I have option that contain antibiotic and steroid together, I will be happy to choose this option, but it's not there. Okay? If spontaneous labor does not ensure, okay? Delivery should be after what? After steroid, or after magnesium sulfate, or after timing, after 10 days course of erythromycin. You get the point there? Clear, my dear? Yes, if the patient now turned into having active contractions of labor, this is a very good question in the chat box. If this patient now turned into active contractions of labor, I will give the benzyl penicillin as per the guideline for prevention of the group B streptococcus in the neonate. Okay, Guy? Okay, everyone? Clear? So yes, Dr. Alia, this is a very good question, very valid question. And for the lady who's taking oral, once she's in active labor, we will turn into the IV. IV of choice in this case is the benzyl penicillin. Okay? Clear. Any doubt for this question, my friends? No? Okay, great. Let's move to the next. We give 10 days, my dear, as per the guideline, okay? Or until the delivery is active, whichever is sooner, okay? Okay, dear? If she reached, for example, everything is fine and the MDT decided that we will leave, okay? And this patient reached while she had a PPROM, any patient who had reached the 34 weeks and she had a PPROM, then we can induce, because at 34 weeks, now the risk of prematurity is lower than before. And the baby is now able to actually tolerate the delivery without high risk of mortality and morbidity, okay? For suspected labor, Dr. Fatima, she had a very good notice. Suspected labor, magnesium sulfate, no magnesium sulfate, it need to be established labor. Well done, okay? Erythromycin, 10 days, and steroid, established labor, then I will give the magnesium sulfate and the benzyl penicillin. Yes, you are asking Dr. Fatima about the clinical management in real life. Yes, we will do, but don't forget the rule of steroids, of course, that you have already given at the time of suspected labor. Okay? So yes, this is a very good practice point. Well done. So look, my friends, here we have a next question. Let's see what is the next question? We have a 34-year-old attend for induction of labor at how many weeks? At 35 weeks. She presented with preterm pre-labor rupture of membranes, okay? At 28 weeks of gestation. A course of oral erythromycin and IM steroids have been completed. Okay, so she had the erythromycin already, she had the steroid already finished. And all maternal and fetal observations, normal. No known allergies. So what are you going to do here? For this case, who comes for the induction of labor? Well done, everyone who answered B. Okay, so I know before I go to the options, okay, that I should give the lady, okay, the benzyl penicillin in labor, which is the question of Dr. Alia before. Okay, so now the lady that comes to me and she needs the intrapartum antibiotic prophylaxis should receive, okay, the intrapartum antibiotic prophylaxis, okay, once she is in labor, once we say intrapartum. So once labor started, I will give her the benzyl penicillin. If there is any option to say that, options available says, this is, guys, you have confusion in the MQs in the exam, that because options are very similar to each other, okay? So now, benzyl penicillin, once inactive, first stage, no, okay? They didn't say active or passive. They said once labor starts. So benzyl penicillin before induction of labor. No, I need her to be in labor to give the benzyl penicillin. Benzyl penicillin once labor starts. So once labor starts, that's mean, yes, this is the most correct one. If there is any other option, let's see other options, because in exam, of course, you have to screen all the options. Ceftriaxone plus amoxicillin once labor start. Is that the regimen that we want? Is E the regimen? No, this is not the regimen. Ceftriaxone and metronidazole. No, not the regimen. Erythromycin once in labor. Oh, this is not even near to the truth. Benzyl penicillin at least 4 hours before delivery. No, nobody say this. Ceftriaxone, no, completely wrong. Ceftriaxone, completely wrong. Benzyl penicillin for 24 hours. No, actually, we don't know how long the labor will take, right? So the best option among the available one is once labor started. Yes, my dear, Dr. Aisha, my dear, the lady already, she had rupture of membrane, okay? Okay, so once I put her on the induction of labor and she have the contraction, this is what's called intrapartum antibiotic prophylaxis. Okay, I don't need to wait till I have 4 cm of dilatation and regular contraction. She might spend some time in the latent phase, Dr. Aisha, and you know, for induction, sometimes the latent phase takes long. Would you leave her all this time without protection? No, excellent. So now you agree with me that the best among these 4 options, A, B, C, D, that contain benzyl penicillin, is the one that is in line with the guideline that once labor started, correct? And for how long would I give the benzyl penicillin? This is the question of Dr. Bhavna. So look, my dear, simply I give the 3, okay, gram of the benzyl penicillin as induction dose. This is the first dose I give. And then I will give 1.5. This is a half dose. Every how many hours? Every 4 hours. Till when? Till delivery. Okay? I don't have a specific frame. Okay? So I will give 1.5 every 4 hours. Okay? And so on till the patient deliver. Let's say Our patient, she delivered fast after 6 hours. Okay, protected. Okay, dear? So no problem if prolonged labor or not prolonged labor. You are welcome, Dr. Hanan. So answer here is B. And the next question. Next question is about 35-year-old spontaneous vaginal delivery at how many weeks? At 39 weeks. In gestation in her second pregnancy. Her first baby was affected by early onset group B streptococcus infection. So if a first baby affected, what should I do? Once I have a first baby affected, that's mean give. Yes, excellent. Give. Okay. I don't want to repeat the tragedy of having a first baby with sepsis, so second baby can have the chances of sepsis. Okay, good. 3 doses of prophylactic antibiotic were administered during labor. Okay, good. All maternal and neonatal observation normal. So I'm quite reassured. So what do you think? Shall I leave the baby without any observation after delivery? I'm waiting your answers, my friend. I'm not saying anything until you have time to read the options. No need to observe, are you sure? Okay, whom I'm observing, my friend? Which baby I'm observing? High-risk babies. Who are the high-risk babies? Everybody knows that if you have a baby and the baby, a mother, so for example, okay, the mother, she did not receive adequate, right? Prophylaxis. What is the adequate prophylaxis? Anybody will know? Everybody know this? What is the adequate prophylaxis? Adequate prophylaxis, so at least this is for the lady who require antibiotic prophylaxis. Okay? What is the adequate prophylaxis for her? At least receive the antibiotic for 4 hours before the onset of labor or before the baby comes out. Right? So means that the baby had 4 hours, okay, antibiotic can start working at that time. Okay, so for the lady, we are revising concept here, okay? So the lady who did not receive adequate antibiotic prophylaxis or decline, because some ladies actually, they don't like antibiotics, okay? She declined or she did not receive adequate antibiotic prophylaxis. What is the recommendation for the baby? The baby will be considered here as high-risk baby, right? So for that high-risk baby, what is the observation after delivery? Number one, you need to remember, neonatologist will be involved. Baby will at least stay in the hospital for 12 hours, at least. And during that time, they will do observation. And the observation, okay, are considered as at 0 hour, okay, and at 1 hour after the delivery, and then after another 1 hour, that's mean 3 times of observation, 0, 1, and 2. And that's it for 2 hours? No, we said 12 hours. So how I'm going to do the observation for the next 12 hours? I will do the observation for the next 12 hours at 0, 1, and 2, and then every 2, right? Yes, correct. So this is for the babies who are at risk of the neonatal disease, right? Okay. So how about baby of a mother who had a previous, this mother had a previous GBS disease? Look, my friend, the guideline deal with them as the same, still high risk, still this baby is high risk, and still this mother, she will be so worried about her baby, correct? She had a previous baby with sepsis, so currently in the pregnancy, oh, really? I'm sorry, maybe I clicked by mistake. I was so excited, in answer. I'm sorry. Maybe I actually, okay. No, I think I just missed it up. Okay. This is one question, two questions. I'm sorry, guys. I'm just speaking. I'm sorry. Okay. Just speaking, and I don't even look to that one. Which question is this? Yes, this one. Okay. So this was the question where we stopped. Okay. And I'm sorry if the screen was misleading. Okay. So now the lady who had a previous baby with a GBS, okay, group B streptococcus, affected baby. And she received 3 doses of antibiotic during her hospital stay in this delivery. After she delivered, what do you think should I do? Send her home without special observation, or I will run close observation for 12 hours like a high-risk baby? Which one you will go? I will go for high-risk baby, okay? Look, my friend, again, this lady, it can be a medical legal problem afterwards, right? Right. The lady, she had already a baby affected. You don't want the second baby, okay, to be affected, right? Because if she had this tragedy once, she shouldn't have it a second time, right? And of course, my friends who are expert, there is a tricky point in the guideline that says the same for the baby observation. And I'm sending you, dear friends, here just a screenshot of this part in the guideline. So, comes in exam. Mother have a previous baby affected, okay? And the previous baby who is affected before, now she received the antibiotic. Shall I do what? Shall I deal with this pregnancy and this delivery as high risk and this baby as a high risk neonate, or deal with this baby as like no risk because she received the antibiotic and sent home? So what I will do, I will deal as a high risk. Okay? So what is the answer? Answer here will be E. I need you to remember at 0, 1, and 2, and then every 2 for how many hours? For 12 hours. Okay? Which answer match what we say? Yes, E, because already the neonatal observation at birth is done. So the frequency afterward will be 1 and 2, and then every 2. Yes, E is the correct answer in this scenario. Okay, and we're writing in the feedback everything. Okay, so you can guys revise in the feedback. So answer is E, 1 and 2, and then every 2 for 12 hours, okay? Because this baby would be considered as high risk of neonatal disease, okay? No, if, look, my friend, Dr. Bavna, my friend, look, if the mother already received antibiotic, she had only been carrier, she's a carrier, okay? No previous history of anything, just a carrier. And she received appropriate antibiotic prophylaxis in labor. Baby is not at risk خلاص, okay? No need for special observation, okay? So which baby had no need for neonatal observation? Which baby that have no need for neonatal observation? Because this baby, the baby whose mother have been carrier of GBS, and she received the antibiotic more than 4 hours during the time of labor, so no require of special observation, okay? So you have to differentiate between which need neonatal observation and which babies does not need neonatal observation. The baby who need neonatal observation is a baby whose mother declined antibiotic, did not receive appropriate antibiotic, or there is a previous history of affected baby by the disease. So 3 conditions for close observation. 1 condition for no special observation required, which is condition is mother is only carrier, no previous history of disease, and she received appropriate antibiotic during labor, no special observation required. Clear, everyone? Clear, Dr. Nora? Pyrexia in labor, this is something else, okay? Yes, so the one who have pyrexia in labor, this is already she is at higher risk of infection. She is already affected. Something caused the pyrexia in labor, okay? But here we speak only about the prophylaxis in a case that not diseased and the baby observation is normal. Even if the baby observation is normal, we continue observation if high risk is identified. Okay, friends? Dr. Nihal Adam asking what a complete dose. So again, intrapartum, antibiotic prophylaxis, 3 gram at induction. Okay? Then after 4 hours, 1.5. Okay? Then after another 4 hours, if labor continued, then 1.5 till delivery. If the lady received this first round of antibiotic, I consider this as completed or appropriate protection. So at least she should receive this in more than 4 hour time, okay? Okay, dear? So she received the first dose, induction dose, and received the second one, the half dose. So in this case, I'm happy that, or I'm reassured that she received the appropriate antibiotic. Because labor, we are not sure, Dr. Nehal, how long would it take, right? But this is the least minimum that we need. Clear, my dear? This means that enough, it's called appropriate protection, but it's not enough, Dr. Ala. Means that if labor is continued more than this, I will say if first 2 doses are enough. No, I need to continue as long as labor is still progressing. Baby is still at risk. Baby still will be exposed to the bacteria. Baby need more protection after 4 hours and so on. Okay. Yes, if she delivered, fine. Okay. So the guideline they just to make it specific that appropriate protection at least for the 4 hours. First and second dose. Dr. Aisha asking, mother carrier, no previous baby, and she did not receive antibiotic prophylaxis in labor. What is the neonatal observation? So my friend, everyone, could you please answer Dr. Aisha? So I will check you are following or not. Yes, yes, frequency, because it's a very important question. It's a recall one in the MQ. Came recently. 0, 1, and 2. And then every 2, we will sing it all together. Yalla. Okay? Until 12 hours. Okay? We will find the way. Yes, we make it a song. Okay? Okay. This part clear? Good. Alhamdulillah. Okay. Let's move to the next. Next, a 20-year-old student has been immunized against rubella 2 weeks before traveling to the UK. She attended the emergency because she missed period, and she's found to be 10 weeks pregnant on ultrasound. She's concerned about the effect of vaccine on her fetus. So what do you think? I need you please to tell me, what do you think? Before looking to options, okay? We actually advise to wait for 1 month, right? This is the advice. But what happened is the lady, she got already the vaccine, not the infection, vaccine. Okay? So what are you going to do? Hi, Dr. Bria, good evening. Yes, we take caution, but actually we will not advise termination, right? No, 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 we don't need to do termination, okay? But if the lady, she had active infection of the rubella, okay? And there is high risk if the baby catch the rubella, then this baby will be anomalous and so on. Okay, we can run test, and if we proved baby have the infection, got the infection of the rubella, then will be termination. Okay. No, termination advice for the termination of pregnancy, Dr. Fatima, after vaccine is not recommended. So everybody can hear the voice? Is voice clear? Yes, so thank you very much. Okay, so you got the point, guys? Okay, yes. Yes, they are not advised in the pregnancy, of course. Okay, not advised if you have a lady who have, okay, the, yes, Dr. Bhavna, I don't advise that somebody, okay, is exposed, for example, okay, to a teratogenic drug. I'm not advising, correct? That somebody has to use a contraindication drug or teratogenic drug. Then this person by mistake have the drug and found that she is pregnant. Shall I advise immediate termination of pregnancy? Can I do this? Do you have a proof that there is teratogenicity occurred? Let's look to the other options. No, no, no. Look, my friends, look, my friend, Dr. Hanan, everyone, okay? Look, what is the option? Okay, and you tell me. Offer termination of pregnancy. Can I choose this option? If you choose the termination of pregnancy based on vaccine, this is very aggressive. Not recommended. It's written, okay, in the, yes, in the government recommendation. So I can't, there is no justification for offering termination of pregnancy because she is exposed to vaccine only. Okay? Even if somebody exposed to infection, I have to prove the infection. And I have to prove that this infection had a neonatal effect. Then when I have proof that the neonate is affected, then terminate. You got the point? So I can't offer termination of pregnancy. This is wrong. Can I give IV zidovudine? No. Shall I do now at the 10 weeks? She had already the vaccine before coming to the UK. Okay? And I'm not sure what is the time. I'm not sure what is the time. So he didn't tell me when she traveled to the UK. What he told me, she is 2 weeks before traveling to the UK. And she attended the emergency because she had missed the period. And she is found to be 10 weeks pregnant on the scan. So I don't even have time frame. Okay? So shall I offer the amniocentesis now? No? Okay? Im immunize neonates against rubella? Actually, all the neonates will have received, will receive, but not at the time of delivery. They will receive the MMR at 1.5 years. Okay. IV acyclovir? No. Amniocentesis and PCR for viral viremia? No, I don't need also amniocentesis. Can people get infection because they received the vaccine? No. Okay. Offer rubella immune globulin? No. Intrauterine therapy for what? No. Reassurance, what I will do in the reassurance? What I will do in the reassurance is that it's unlikely that she got the infection, active infection, okay, from the vaccine. And what we will do is we will follow up the pregnancy and she will have the chances to do the dating scan and she will have the chance to do the anomaly scan. And if there is any anomaly appear at this time, or any problem appear, in this case, she will be referred to the fetal-maternal medicine unit and will be diagnosed, the baby will be diagnosed, and then we can take decision. Right? Correct or not correct? So I can see I don't have any other option rather than this. No need to panic right now and offer her termination. What most people will do? Most people will choose A. Okay? This is what most people will do, while it's not, okay, advised after exposure to the vaccine before pregnancy or even when she's early pregnancy. I don't have any idea about the time frame. They give me only that she had exposure to the vaccine. This is not a justification to offer termination of pregnancy. Okay? Dr. Bhavna, my dear, I don't do any amniocentesis to anybody unless I have proof of infection of the mother. Can I do this? Can I do this? No, I can't. Okay? So when you have a mother exposed to infection like CMV, like rubella, like anything, should be investigated urgently. The mother, urgently. First, prove that the mother have infection. And then look for the fetal infection, evidence of the fetal infection. Good the point, guys? Anomaly scan will be, yes, checking the baby further, not only at the anomaly scan, it will be even starting from the dating scan. Dating scan, take all the screens, everything. She will continue the pregnancy till she had the 18 weeks anomaly scan. At the 18 weeks anomaly scan, she can be assessed by a specialist. All of this will be done, okay? Yes, all of this will be done, but no need to do something urgent now. No need to offer termination now. And as I told you, I don't have any other justified plan in the options. In the options here, what I have only is I reassure her at the meantime that we will take care of her. Good point, guys? Reassurance doesn't mean that I am, okay, declining any risk. No. Reassurance is just I am, okay, telling her that we all here to help you, okay? And we will take our steps in order to ensure the safety of you and your baby. Okay, in the part 3, inshallah, we will have these types of discussion, right? Because even sometimes we see something in the scan, but I can't make the woman panic, right? We take things stepwise approach, my friend. Okay? You got the point? Yes, if I have that, she will have a good plan for follow-up and will be referred to a consultant. The consultant will have a plan for the scan. The scan will be done by a specialist. Yes, if I have this option, I will go for it. Other than this, I'm left with only to reassure her at the moment. Okay? So, reassurance, my friend, in your exams doesn't mean no risk at all. Okay? Does it equal no risk at all? No, it doesn't equal no risk at all. It means that I no need to panic the patient now. There are things that we can do before we are sure that the baby have already harmed or not. Okay, so we're just showing you ways, my friend, to answer this question if it comes to you in the exam. You have to be also familiar with the expressions and the words that's used in your exam. You know what? I am not a native speaker, of course, of English. And some of the sentence in the guidelines and in the questions, when I first prepared for the MRCOG, was challenging to me. I don't understand what is behind what they're writing. What is the meaning of this? Right? Then with the experience and with exposure, okay, to the British society and to by the work experience and by working in the guidelines, you know, reading, summarize and all, okay, you get that point, you get this view, okay? What does it mean by the people, okay? They are very conservative. They don't like to make a fuss, okay, before ensuring that there is actual harm happened, okay? "30-year-old is known to be rubella immune and is concerned about taking her 3-day-old baby home because her 10-year-old stepdaughter has rubella." I know, taking you to the basics of infections, transmission. Mother is immune, right? If the mother is immune and the baby is so young, 3 days, baby have antibodies or not? Yes. Okay. So what I will do here? Yes, have passive immunity. So what I will do here? Should I give in anything like zidovudine, termination, acyclovir, vaccine? No, just reassure also, right? Yes, well done. Here, my friends, a 35-year-old woman admitted to the high dependency unit, okay, at 27 weeks of gestation with P. falciparum malaria. Malaria now becomes more important than before in your exams, okay? She's being treated with intravenous artesunate. The artesunate is the drug of choice to treat the severe anemia because of the CTG show baseline fetal heart rate of 190. Is that okay? 190. No deceleration. Temperature is 38.9. And pulse is 120. And blood pressure is 120/80. So, dear friends, what are you going to do? So if she's receiving the artesunate, anything that I can do for the fever? Yes, of course. The IV paracetamol, simple and easy. Yes, yes. Excellent, well done. Okay, so after receiving the paracetamol and after managing hair, like for example, we can give some fluids, we see, okay, that some measures to reduce her body temperature. After her body temperature comes to the normal, I will check the baby. But most likely, because she had fever and she had tachycardia, baby have this heart rate because of it, okay? Right? Yes, everyone answered correctly. So well done, everyone. IV paracetamol is the answer. The 33-year-old attended the antenatal clinic at 18 weeks of gestation. She traveled to area with Zika virus transmission is known to occur, and she's returned 8 days ago. So she's traveled when she was 16 plus, right? Plus 5 days or 6 days. She gives 2-day history of feeling generally unwell. Oh my God. So she traveled and she's coming unwell with headache, red eyes, and muscle and joint pain. Temperature is 37.2 and the pulse is 96. Blood pressure 108 over 80 over 56. Sorry. So lower blood pressure. Fetal heart rate is 148, and test for infection, including Zika virus, is negative. So what are you going to do? Okay, repeat the test. Okay. Yes, so do I need reconfirmation in the cases of Zika virus infection? Anybody need? One second, my friend. I need to have, okay, 1 second, 1 second. Okay. One second, I want to show you, okay, the Zika virus algorithm. 1 second. Just please give me a little bit of time so I can open it. I want to show you how the things are going in the Zika virus, okay? Bismillah. It's so slow. No problem, my friends, because in the Zika virus algorithm, very important, my friend, that you see, okay, the difference between in the algorithm for the woman who had exposure and symptoms and the woman who have exposure and no symptoms. Okay, so our lady here, from which category? The lady here. I hope that it's open. I don't know what's wrong. Bismillah. Yes, she had exposure and she shows symptoms. Yes. Okay. I'm sorry, my friend. Is that just because I am conducting a live meeting? Opening other applications can be very slow. Sorry for that. Oh, it takes more time, and my friends, they have exam, and I don't want to waste your time. No waste of time. Bismillah. Yes, this is the revised algorithm, page 25. Open it, inshallah. Okay. Tips and tricks. Wallahi, I know. Okay, I'm just trying to give you some advices, but seems like it will take forever. Alhamdulillah, internet now is better. Hundreds of applications are opened in the background. Very bad. Okay. Bear with me. I'll give you a gift after we finish. Okay? So, thanking you for your patience. Oh, poor Dr. Rabah. Very bad in internet and things like this. Okay, okay. Everybody is sending things. Finally open, alhamdulillah. Oh my God. I even send it from the mobile is easier. I don't know what's wrong with the computer. Okay. Yes. Me. I am the one who shared it in the group. Okay. So this is, yes, in the tips and tricks, page 25. Bismillah. 25, 25, 25. Yes, it's the computer is slow because I'm conducting meeting. Otherwise, the laptop or mobile can be more faster if not conducting a meeting. Yes, this is the Zika pregnancy, okay? You get the point, guys? Here, look. This is the algorithm, right, of the Zika. So what happened in the start of this algorithm? They tell you that pregnant woman with history of travel during pregnancy to a country or area with Zika virus transmission. Okay? But you do have two things. Okay? You do have a woman report the clinical illness. Here, I'm using this red, okay, to show you. This is for the woman who show clinical illness. There is another woman who does not report the clinical illness. This is the here number 2 pathway. Which pathway we need now is the woman who have, okay, with the clinic, with the illness, okay, that during or 2 weeks of travel or sexual contact with potentially infectious partner. The patient is currently symptomatic or the symptoms have resolved. If the patient is currently symptomatic, if she shows symptoms, you will submit serum for testing at the repel. Okay? Also need urine if within 21 days of symptom onset. Offer baseline fetal ultrasound screening. So how many things you will do if the woman present and she have shown the symptoms? How many things? 1, 2, 3. 1 is sending serum sample at the repel. 2 is sending urine within 21 days of the onset of the symptoms. 3 is baseline fetal ultrasound screening, correct? Okay. If I have here symptoms resolved, how many things should I do? Submit serum for testing at the repel. 1. Also send urine within 21 days of the symptom onset. 2. Offer baseline fetal ultrasound. 3. Okay? Okay. The special laboratory, Dr. Nora, okay, because this notifiable journals, okay, and special laboratory for confirming infections. You get the point? Okay, so now what if the result comes negative, like our case here? If the result comes negative, my friends, okay, then look here, antibody and PCR. Confirm negative Zika antibody test result on a further serum sample if appropriate. And if the second one comes as negative, this is 1 negative, this is 2 negative, what I will do, return to normal pregnancy care. Okay? So, 3 things I need to do when the woman have the symptoms. What are the 3 things? Again, submit serum for testing at the repel. Send urine if within 21 days of the onset of symptoms. Third is offer baseline fetal ultrasound screening. Okay? 3 things that you need to do when the woman comes with symptoms. Why the screening, the baseline ultrasound screening is important? Why? Yes, because you have to compare. You have to follow up, right? Okay, so that's why here the answer to this question, okay, is if. What if? Okay, see, here, my friend, baseline fetal ultrasound and repeat every 4 weeks, okay, or reassure or repeat test for Zika virus in 1 week, or ensure anomaly scan is undertaken by the fetal medicine consultant. Did they say anomaly scan or say baseline ultrasound? Explain that the Zika virus cannot be excluded, or fetal MRI scan, or repeat test of Zika virus in 48 hours, or repeat test for Zika virus after 3 weeks, or fetal MRI at 18 weeks, or ultrasound scan to exclude microcephaly. So look here, my friends. No, this is wrong. This is completely wrong. Okay? And repeat the test for Zika virus for after 3 weeks is wrong. Okay, fetal MRI is wrong. Explain that the Zika virus disease cannot be excluded. Yes, of course. Okay, I can't exclude it until I have a confirmation, but this is might be a correct answer. So I will put it in my differential diagnosis. So G can be my differential diagnosis, F can be, sorry, my options. And ensure anomaly scan is undertaken. No, he didn't say anything about the anomaly scan. Okay, repeat test for Zika virus in 1 week. They didn't say at 1 week. Okay, reassure. So when I say reassure, I should have a base, so wrong to reassure, right? Okay, so when to do. Let's go and see algorithm again. No problem. Okay, so we have the algorithm with us, so we will go for it. Complete the algorithm. Okay, my friends. Okay, so look, my friends, here. Okay, now, if the woman does not report the clinical illness consistent with Zika virus disease during or within 2 weeks, or travel to the sexual contact with potentially infectious partner. Okay? Okay. Take and store clotted serum sample. Offer baseline fetal ultrasound, again at 12, at 18 to 20, or at the same visit if the first visit is later than 20 weeks. If ultrasound is normal, consider repeating at 28 to 30. If abnormal result finding or abnormal ultrasound, okay, like a small head or intracranial calcification or additional concern, refer to fetal medicine unit. Okay, so friends, now I would know that for the case who have no problems, okay? Okay. This case who have no problems, did not show the symptoms consistent with the Zika virus, right? I will still take sample and store, and still I will do the ultrasound, correct? Okay? Yes. Okay. So in the details of the frequency of the follow-up, let's see what is the guideline says. Because I can see, my friends, that you have like a doubt of what to do, what not to do. Okay, right? Then the serum sample and anomaly scan. This is for the woman who did not show the symptoms, right? Okay. So I would like to do for this lady, okay, the baseline investigation. What is the baseline investigation that I need to do? I need to do the three things. So I said the three things. Now repeat it again. The three things, the serum and urine and the baseline ultrasound. Okay? Okay. So in the RCUG guideline for the Zika virus, they said that pregnant women with history of travel to a country or area with Zika virus transmission or who have had symptoms consistent with Zika virus disease during or within 2 weeks of travel. Okay, this is the details that comes in the algorithm, but it's from the guideline, okay? In like written in more details, in case you didn't read the guideline. Okay, so what we will do for her, okay? First, it should be tested, okay, for the Zika virus infection, submitting appropriate sample to the repel, okay? And the appropriate sample, this is the serum samples, right? And the urine if the symptoms within 21 days. If they are significantly unwell, and particularly if they require hospitalization, offer travel-associated infection, okay? Like the malaria, for example, must also be considered. If the laboratory testing show evidence of Zika, then in this case should be received the fetal ultrasound, and then if not already done, then it will be referred to the fetal medicine unit. Okay, but if it's not detected, sample will be collected 4 or more weeks after the last possible travel. Okay, so the 4 weeks or more after what? Last possible travel associated or symptoms or the sexual exposure. Okay? Then recent Zika virus infection can be excluded. So pregnant women with negative antibody result from the such sample don't require further extra fetal ultrasound follow-up, okay, unless there are additional concerns. Okay? Yes, this is the 4 weeks, yes, or more from the last possible travel associated, okay, or sexual exposure. Because I'm not searching about the first test and second test, I'm searching for the infections, okay, the infectivity period and the period where the virus can show symptoms, right? Look, my dear, if you have done one and consider the second one, but it's 4 or more weeks. Okay? Any any association, my friends? So now, according to this algorithm, right, they said that if it is negative, you will confirm a negative antibody test. You got the point? But the question of your friends asking about how I can decide for the time of repeat the testing. This is for weeks. Okay? No, yeah, no, dear. I don't know what's your name. It's written iPhone. Okay, so would you please write your name is so this is for good communication? Heba. Okay, so Dr. Heba, this name, nice name, Dr. Heba. One of my best friends called Heba also. So I like this name so much. So look, my dear, Dr. Heba, the thing is that you have to follow in the algorithm, right? So what should I do for this case? I should perform the baseline ultrasound, right? When shall I repeat? And I should also do the serum test. He gave me that the serum test result is negative. So alhamdulillah, this is one negative. Okay, I need a second one, right? Do I need a second one or not? Yes, I need a second one. But do I need also to have the ultrasound, the baseline ultrasound with me or no? Especially in the lady who show symptoms already, showing symptoms, this is high risk of having the disease, right? Yes. Okay. So here, my dear, what I will choose. What is the most appropriate, okay, answer of the options available? Let's see the question again. What is the most appropriate answer for the lady? Okay, 2 days generally unwell with headache, red eyes and muscle and joint pain. Okay? So the red eyes and muscle and joint pain, this is consistent with Zika virus symptoms or not? Okay. So now the first one is negative. So what is the second one? The second step after the first one is negative. We said this one I will not go for. This one, no. This one, or it can be G, it can be. Okay, so I'm sorry. We said E here, this one, ensure anomaly scan. No, no, no. Okay, and I have baseline. Okay, I have fetal MRI. No. I have J. No. So now I am left with options A, reassure. No. B says that repeat the test of Zika virus in 48 hours. Is the 48 hours came in the guideline? No. Okay, so here, no. Repeat the Zika virus in 1 week. Not mentioned also in 1 week. Okay, so Zika virus after 3 weeks. No, 3 weeks is not there. Okay, so would I need to do the baseline fetal ultrasound? This is could be, okay? The first part of this answer is correct. Yes, I need to do the baseline fetal ultrasound. Shall I repeat? Here, I would say something about the writing the question. Maybe this is what confused you, okay? That this is after 4 weeks, okay? Not every, then this after, because after that, I will decide what is the thing, okay? So I will say here that this is after, okay? So do the baseline fetal ultrasound according to the algorithm, okay? And then repeat the investigations again if the first test is negative, and the guideline would say that this is, you will do it 4 weeks from the last exposure, okay? No, we don't count it like this, my dear. Okay? They don't test us in math, believe me, okay? Okay, my friend. So what if now we will know what is the lady who have, what about the lady who have the first test negative and I need to repeat again at the second sample, okay, if appropriate. What if the lady have positive? No, termination. Why? Termination. Why you are so aggressive with termination? Look, my dear, if the woman have the infection, does it mean 100% the baby got the virus infection? And if the baby got the virus infection, is it 100% the baby will be anomalous? No, right? So this is God mercy on us, okay? That not every case exposed to infection get the infection. Not every case got the infection. Her baby got the infection as well, not 100%. And even if the fetal infection occurred, alhamdulillah, okay, not all the babies show anomalies. You got it? You got that? Not everything written in that algorithm, Dr. Alia. I just want to show you that the baseline ultrasound is must. Okay? The baseline ultrasound is a must. I can't just leave it. Okay? So, Dr. Nihal, I think you are speaking about the other arm of the algorithm. So what about if the lady who shows symptoms found to be positive, either by the PCR or by the antibody test? Will I need to repeat sample? Yes, you will submit further sample as well, as advised by the REPEL. Refer to fetal medicine service for further evaluation and follow-up. Okay? So, again, Further sample will be still required, even if the first one is positive. Further one is required according to the recommendation of the report, and will send it to the fetal-maternal medicine unit. Okay? What about the other arm? Other arm of the Zika virus here. This is the one that where, okay, the woman did not show symptoms. Okay, my dear Dr. Nihal? If the woman did not show symptoms, okay, or show other symptoms and you're still confused, I will do a baseline ultrasound. Yes, baseline ultrasound will be done. Okay, and according to the gestational age, I can, if she's early in pregnancy, I can repeat it again at the time of the congenital anomaly scan. I will take and store clotted serum sample in case that in the future baby show problems. Okay, then, and again, I will have a sample at 18 to 20 weeks at the same visit if first visit is later than the 20 weeks. If ultrasound is normal, consider repeat the ultrasound, the normal one, at the 20 to 30, 28 to 30. This is the part, Dr. Nihal, you're asking about, correct? This is your comment, okay? If abnormal ultrasound finding, like a small head or intracranial calcification or additional concern, then the case, of course, will be sent to, or she will visit, okay, the fetal medicine unit. Correct, my friend? Yes, Dr. Yes, Dr. Heba, if both the result comes as negative or positive, both are required sending further sample. Yes, Dr. Ala, you are asking either negative or positive test. Repeat should be there. Yes, repeat should be there according to the recommendation of REPEL. If negative, we have to confirm negativity, and then if positive, then submit another sample. Okay, yes, exactly. And if positive, of course, the fetal-maternal medicine unit will deal with the case. Otherwise, if second negative, just release her, okay, to the normal pregnancy care. You got the point, guys? So I warned you from the very beginning, this is going to be tricky questions, okay? And this is not, by the way, it's just ensuring a deep understanding of the guidelines, and it can help you to solve any MQ if it comes in your exam, because the MQ are not funny at all, I know. Okay, so let's move to the next question. Because I do have a practical point to do, Dr. Aisha. I didn't complete what I required to do. What I required to do is to do at least the baseline fetal is ultrasound and send the next sample, correct? Yes. Okay, so here, 30 years old with previous genital herpes, presenting spontaneous labor. So this is a recurrent herpes, okay? Or she had a previous genital herpes. She presented that labor at 39 weeks of gestation. No recurrent lesion, no prodromal symptoms. She's worried about her baby contracting the infection. So what is your answer here? So currently, the lady in a spontaneous labor, right? And she's not having any problem. So what I will do? Yes, just to be sure. Well done, well done. Right? Yes, yes. Okay, good. A general practitioner telephones for advice about healthy 34. No, I don't need to give passive immunity. Why? She does not have anything now. Okay. General practitioner telephones for advice about a healthy 34-year-old who had developed the chickenpox rash at 24 weeks of gestation. Okay, so let's see the fun in this question. So, 34 years old woman developed rash already, chickenpox rash, 24 weeks of gestation. This rash appeared 24 hours ago. Bye-bye, okay? And the woman is clinically well. So if, according to the chickenpox, okay, right? What I will do? So everyone, okay, good. Okay, so you are guys saying that you're not sure about the need of a scan, right? So this lady need a scan or doesn't need a scan? She'll need a scan, right? She'll need a scan, right? Okay, so when to do the scan? Okay, so the question here, my friend. So the question here, for the varicella rash or the chickenpox in pregnancy, okay? In a chickenpox of pregnancy, when to give the acyclovir? Now, the acyclovir is considered as post-exposure prophylaxis if the lady, right, exposed, right? Otherwise, if not available, what you will do? Yes, in this case, the immunoglobulins will be the alternative, okay, if the acyclovir is not contraindicated, not tolerated, or not available. Okay, second option will be the immunoglobulins now. Okay, so the first option will be post-exposure prophylaxis for the acyclovir. This is the point that I need everyone to clear, okay, before your exams. It's very important, my dear friends, because this is the update in the guideline of the varicella or chickenpox in pregnancy, okay? I'm also going to send you the algorithm in the group, okay? And I'm not sure here. Sending WhatsApp. So everybody confirm received the algorithm or not? Yes. Okay. So first use of the cyclovir. This is about the guideline, not about the question in front of your eyes. This is about the guideline update, which is very important in your exams. Why? Because this is the point that it's changed from before. Okay. So if this point changed from before, now I need to take care of it. It will come in the exam 100%. Okay. Okay. Okay, for any case, my friends, who developed already chickenpox in the pregnancy, how I will know that she developed the chickenpox in pregnancy? by appearance of rash. Okay, so for this lady who had the infection, confirmed the infection, okay, I will need to check the ultrasound. Why the ultrasound after 5 weeks? Because in the ultrasound, I will see it need time for the fetal infection to occur, for the effect on the of the virus to the infection. So I will need the ultrasound evaluation. Ultrasound evaluation will be after 5 weeks of the infection. So the point here that is most important, okay? And now I wanted to clear it to everyone. I'm looking to your answers in the chat box, okay? So I'm looking to everyone here in the chat box, okay? So the question is, if the rash appear, can I give a cyclovir or not a cyclovir? Within 24 hours. Yes, very important. That's a very important in the algorithm. That's why I sent you the algorithm, guys. Okay, and I'm going to send you the other proof. Okay, yes, that the rash within 24 hours of the exposure, I can give the acyclovir. Consider or recommend, this is, will depend on how many weeks of gestation. If below 20 weeks of the gestation, I would consider, right? If above 20 weeks, I would recommend, right? Yes. Okay. Yes. Good. So now, if the rash appeared more than 24 hours ago, what I would do? Then I would have the symptomatic treatment. If the lady is, if the lady, my friend, she is, yes, the symptomatic treatment, of course, okay? If the lady show severe signs or symptoms, okay, then I will give the acyclovir, IV even, right? For the lady who have extra or additional risk, like the lady is a smoker, okay? So this lady will need admission and will need to be dealt with. She will receive the acyclovir, okay? Okay, so if we changed one word in this question, 1 second, my friend, because I am not so happy. Then the question will be more clear. You can see here. Okay. You got the point, guys? So, if the rash appeared within 24 hours, right? Then the answer would be the B1 that everyone ran for. But if past 24 hours, the effect of the acyclovir after developing of the rash will be less. Okay? You got the point, guys? Only I will give to the high risk cases or severe, that the cases that show symptoms, severe symptoms, right? Otherwise, I can give symptomatic relief, okay? Because the chickenpox itself, most likely it's self-limiting. When I'm afraid of the ladies, okay, who are smoker, immunosuppressant, they have risk factors, or the ladies who show the other manifestation like pneumonia or something like this. Okay, so I'm afraid of the high risk group, but most likely the problem is itching, and it can be relieved with the emollient and with the antihistaminics and the local treatment, symptomatic relief. Okay. If the delivery within 5 weeks, there is no problem, my dear. You just test the baby. How is the baby doing? Okay. Acyclovir can be given below and above 20 weeks. But the thing is, I tell you, it is a story in the UK. That's why there is a changes, or there is differences in the recommendation. What is the story? The story that the drug is not licensed in the UK to be used during pregnancy in the first 20 weeks. Okay, this is the story. Simple. So what they do is they give it, if it is required to a woman to take the acyclovir below 20 weeks, will be unlicensed medication. Okay, so if it's unlicensed medication, this is will follow the regulation of the unlicensed medication, and they can't say recommend. That's why they say consider. Yeah, here, my friends. Yes, let's go through the varicella. Look, varicella story. Okay, yes. Varicella story. Start with contact, history of contact. Clarify the significance of contact, right? Like, for example, is it a face-to-face contact, or it's in a public place, or what? Or continuous exposure. And the time of the infectivity of the chickenpox is how many? The Yes, the person will start to be infectious 2 days before the rash appear until the lesion crusted overs. So if you meet a person last week, and this person today developed rash, are you at risk? No, 1 week ago, he's not infectious yet. The infectivity period, 2 days before the onset of rash till 5 days of the lesion crusted over. Usually it's 5 days, okay, or until the lesion crusted over. So, dear friends, now I have here past the history of a chickenpox. 2 doses of varicella vaccine received, and it's documented. Like in the medical record, it's written that this lady, she had past the history of chickenpox vaccine, and 2 doses of the varicella vaccine is given, documented in the report. You were reassured, right? Thank you very much. But if uncertain, or no past history of a chickenpox, or the woman comes from a tropical or some tropical country, those are higher risk of no immunity of the chickenpox, because it's not that much, common in tropical and subtropical countries. So what they will do, you will check the blood for what? You'll check the blood for varicella IgG. If the IgG are present and in a good amount, which is more than 100 international unit per ml, reassure. Thank you very much. No action needed. Reassure. Return to normal antenatal care. But if the IgG not present, or even in a low amount, less than 100 international unit per ml, which means not protective, look, what is the action? Till now, we are speaking about a lady who have just history of exposure. So Give acyclovir from day 7 to day 14 post-exposure, right? Give IgG if there is contraindication to antiviral therapy or significant adverse effect with their use if less than 10 days since contact. So very important here to know that the acyclovir is being used as post-exposure prophylaxis from day 7 to day 14 post-exposure. Okay? Okay. Then the IgG can be given as an alternative or advise a woman that she is potentially infectious from 8 to 28 days after contact. Yes, this is the new update, Doctor. Yes, Dr. Nora, this is the new update. That's why I'm saying this is important in your exam. It's a new update. It will come in your exam. So then discuss this lady, discuss postpartum varicella immunization. Yes, the Irish guideline in the MRCPI, they actually had a step before the RCOG in changing the guideline. And in the UK, in practice, they are following the government, the viral rash, government guideline, viral rash in pregnancy, okay, which is not in the RCOG. But now the RCOG started to change its guidelines. You get the point? Okay, so it's easier now, no conflict. Because I used to have, candidates in the course that practicing in the UK, and they tell me, doctor, we don't do this. I tell, yes, I know, I'm aware. This is not the practice now, but this is the guideline. I have to stick to the guideline. But alhamdulillah, guideline now, it changed and was in line with the practice. Okay. So, women who develop severe infection and women at high risk of complicated chickenpox should be referred to hospital. Intravenous acyclovir should be given. So, intravenous acyclovir should be given for which woman? I will mention, Dr. Noura, don't worry. I actually speak so much. So, I tell everything. Okay, so, friends, intravenous acyclovir be given to whom? To high risk of complication. Inform woman that infection at below 28 weeks is associated with a small risk of fetal varicella syndrome, and it's less or around 1%. Refer to fetal medicine specialist at 16 to 20 weeks or after 5 weeks after infection or 5 weeks after infection. Okay? Okay. So all of this is for the woman who had exposure. The only thing about infection, okay, which is in a high-risk group or severe infection or complicated infection, in this case, consider the, the IV acyclovir according to the guideline. So now, look, my friends, here, avoid if the woman presented with symptoms. Okay, this is the presence with the chickenpox initial contact should be within the woman GB. Avoid contact with potentially susceptible individual like neonates or other pregnant women. Symptomatic treatment and hygiene should be advised. Okay? If the woman present less than 24 hours of the appearance of rash and she is 20 weeks or more of gestation, prescribe acyclovir. Okay? So this is the thing. Prescribe the acyclovir. If the woman presents less than 20 weeks, consider acyclovir. And I told you, okay, consider the acyclovir, okay, and this is based on the legalization of drug use in the UK because not licensed in this gestational age. However, there is no harm reported, but it did not take the license to be used less than 20 weeks. Okay, 100. Dr. Nabila, number is 100. 100 in immune compromised, more than 150. I don't know what did they, sorry to interrupt. So avoid delivery of the baby until at least 7 days since the rash appeared. Okay? To avoid delivery of the baby if this is like induction of labor or something, so avoid, because the baby can take the neonatal varicella syndrome, which is more dangerous than the before. So here, infection at less than 20 weeks of gestation. So what I will do, this is the actions, because below 28 weeks, the risk of developing fetal varicella syndrome is low. Okay, and we need to check by the ultrasound. Okay, friends? So revise this algorithm, please. Yes, Dr. Noura, it's written in the guideline. Okay? So the lady, she will have one ultrasound, no problem. Okay. So here, in this question, a 22-year-old woman attended the maternity assessment unit at 14 weeks of gestation because she had been feeling unwell for several days with a fever, cough, red eyes. Over the last 24, she developed rash, which started on her face, and she spread rapidly to the rest of her body. Okay? Temperature is 37.9. Pulse is 120. Blood pressure 124/68. And the SpO2 is 98 on air. There is a widespread blanching maculopapular rash with erythematous lesion on the buccal. Second. Mucosa. Okay. So, dear friends, what do you think about this question? This is measles, right? Yes. Yes. Okay. Yes. Okay. Next one. Yes, they like to ask some questions from the viral rash. 33-year-old is admitted to spontaneous labor with consent pregnancy. I don't know. Spontaneous labor? Okay. 3 days following delivery of term infant, she is diagnosed with pulmonary tuberculosis. You got a lot of this with the pulmonary tuberculosis. Yes, I think that you had the TB with Dr. Nada, right? Oh, concealed pregnancy. Yes, full screen. Okay. We'll try to make it here. Is it okay now? The thing is that every time I am doing next to the question, it's changed everything. Very annoying, really. Okay. You have no idea. Okay, so listen to the record of TB, doctor. You will treat the mother. Okay. Okay, so look, my friends, options. What are the options available? You will give prophylactic isoniazid. Okay, is that enough? Not enough. Prophylactic ethambutol. Not enough. Okay, prophylactic rifampicin. No. Separate the woman from the neonate. No. Admit the woman and her baby for at least 6 weeks. No, it didn't say any reason for admission. Okay. HIV test on the neonate. Is it only test? No. I should give post-exposure prophylaxis, right? Okay. PCG vaccination. You think that after the exposure I give vaccination? Prophylactic isoniazid, pyridoxine, plus tuberculin test at 6 weeks. Does this seem logic? Okay. Another, okay, another thing is, okay, prophylactic rifampicin, we said no. Separate, no. Mantox test, no. Okay, Mantox test again, no. Prophylactic rifampicin and PCG vaccination at 6 weeks, no. Okay, so what is the, yes, what is the rationale after K? Anybody knows? Okay, yes, yes. When I say prophylactic, this is treatment. So who need the prophylactic? Who needs a prophylaxis? Yes. So do you have option of treatment here for the mother? No? Okay. So now, do you agree that this regimen can be okay for the baby? Yes. Okay. Yes. Don't worry about the mother now. He didn't give you options of the mother. In real life, you will treat the mother. Guys, what is the chances that the baby, okay, got the infection from the mother who have pulmonary tuberculosis after 3 days? It's high. Of course, it's high, right? So give the baby antibiotic, please. So which regimen can I give? Please tell me. Baby diseased or baby at risk of disease? I'm just listening to you guys. Baby after exposure or or before exposure. In the presence of active maternal TB, okay? In the presence of active maternal TB, and there is no clinical or laboratory evidence of prenatal TB, because I don't have anything to refer to the baby, right? Then isoniazid preventive therapy, okay? And the dose is also, look at the dose in the TUG article, 10 mg per kg per day is recommended, okay? With pyridoxine. You got the point, guys? The answer is K. This is a very simple and straightforward one, okay? And I thought that maybe you will think about, okay, what I will do, right? To the mother, treatment to the mother or to the baby. In absence of symptoms in the baby or evidence that the baby caught the infection already, but the mother have active pulmonary disease, okay, baby will receive the prophylactic isoniazid plus the pyridoxine, okay? So the clear answer in front of you guys, don't go to think for other things. It's clear. And it's written clearly in the TUG article. Is the thing that you didn't study the TUG article, which is, okay, today you promise that you'll revise the TUG article, okay? Yes. So, yes, you are trying to defend things. I'm sorry to say that. You are trying to defend things based on no ground, right? Based on that, this is what you think of. No, you didn't read the TUG article. This is the thing. Simply. Inshallah, you read it. Okay? No problem, guys. You still have time. You still have time. Not so long time. It's 6 weeks for the exam, but you still have time to have a look to the missed topics. No problem. No problem at all. It's okay. Next question, my dears. A 32-year-old that tested positive for syphilis. Syphilis, you're one of the beloved ones in the infections for the RCOG. Syphilis at the initial screening test. Which test should be used to confirm the diagnosis? That's very easy. Okay, this is a single best answer question and easy. When somebody had initial screening test positive, what is the next? Confirmatory testing, right? Like what? My friends, okay? In the syphilis of the pregnancy. Yes, okay. Yes, in syphilis in the pregnancy, right? In that TUG article. You do have TUG article and there is guideline. However, the TUG article is nice and easy, right? Yes, okay. So we can just follow it, it's easy. Okay, so whenever we have, yeah, Whenever you have a first screening test is positive, I need to run another screening test, right? Correct? Yes. So when you are running another screening test, shall you run the same type of test or not? No, we will actually need two samples, okay? And the two samples, this one, to send the original sample for a different treponemal serology test, like the TPPA or the TPHA, okay, right? Plus sending another sample, a new sample, right? For treponemal serology, like what? Like the EIA or the CLIA. Correct, friends? Again, this is a TUG article that you have to study, okay? And I will send you the algorithm. Is very easy and straightforward, okay? There are some other questions in the diagnosis of syphilis that are really painful. This is the easiest one that you can have. Wallahi, this is the easiest one. So no way that you can make a mistake in this one. Okay, 1 second, sending to all. Please confirm you have received. Sharing the TUG article. Okay, so I'll ask Dr. Nada to help you with the material because I am that person who is not very fast in technical point. I'm not very good at all, to be honest, in the technical point. So, and Dr. Nada in the MRCOG team, you are all know Dr. Nada. Dr. Nada, she's the one responsible for the material. So, she is the chief officer of material. Yes. Okay. I'll show you the algorithm, my friends, if you can see it. Please confirm. Yes. Okay. So look, my friends, screening and booking. This can be by the treponemal serology to detect both IgG or IgM, right? And IgM can be done by either any one of these, EIA, CLIA, or TPPA. If this is found to be negative, then okay, everybody is happy now. Negative, bye-bye. Okay, if found to be positive. So remember, if there is a positive today, okay, we always need to confirmation. But in this time, they will do, okay, the second test on two samples. Okay, one sample is the original one, because usually when they run the test, this is a booking blood test, you remember, they don't discard the sample. Okay, so send the original sample for different treponemal serological test, like what? TPPA or TPHA, correct? And number two, sending second sample for another treponemal testing. So I did even double confirmation by another type of the treponemal testing, like, for example, EIA or CLIA. You got the point, guys, or not clear yet? So if the sample, first one positive, next would be what? Could be the TPHA or the TPPA, right? Yes. What is not a recognized complication, okay, of malaria in pregnancy? Not. Thrombocytopenia is the recognized complication. Do you agree? Or neonatal anemia. It can cause anemia. What will happen if the baby got the infection? If the mother have anemia, baby will have anemia. If the baby got the infection, what will happen in the red blood cells? Yes. Okay. So thrombocytopenia is known complication of malaria? Yes. This is the answer. E is the answer. Yeah, because thrombocytopenia is not known to be a recognized complication. Anemia is recognized complication, but not thrombocytopenia. Right? Very far from the common complication that we know it. Correct? So E, yes, E is the answer. You don't want the miscarriage to be a recognized complication of malaria? People can die from malaria, not only miscarry, my dear. Okay, so look, my friend, another question, and I promise it will be easy, inshallah. A 23-year-old woman present in a spontaneous labor at 38 weeks of gestation. She complained of vulval pain. On examination, clinical evidence of genital herpes. Cervix is 2 cm dilated with intact membranes. There is no history of previous genital herpes. So this is a primary. What if you have primary? Yes, you will go for cesarean section. Excellent. Okay. Anything that I would like to do with the cesarean section? Everyone choose B. Have a look to the other options, my friends. Is only cesarean section? Is only cesarean section? Not present. There is no option says cesarean section with IV acyclovir. So now I'll tell you something. Okay? Yes, it is. Yes, Dr. Hanan, it is. Yes, I'll tell you something. The viral swab for PCR is required, right? Whenever, yes, Dr. Sadia, excellent. Okay, so whenever we have a lesion of what? Of the herpes, you need a confirmation. Why? Because clinically, okay, sometimes ulcers are not very clear. I can't take a confirmation based on just the clinical examination. We always need to confirm what we are dealing with, right? So the viral swab is very important. And another thing in your guidelines for the swab, you know that herpes, right, can present itself. The woman says, this is my first time, but actually this is not the first time, right? Or Sometimes the lady had a previous infection of herpes, like herpes 1, okay? And she got a second infection by herpes 2, okay? And she think that this is a recurrent herpes. So for you as a clinician, in all the cases, you need a confirmation, right? I know, okay, that emergency cesarean section is required, right? But in this exam, please look to the other options here, and you just say that like this in the exam. It will take few seconds, but it will prevent horrible disasters in the exam. Planned vaginal birth, of course, no. Viral swab for PCR. Yes, I need PCR viral swab, but this is not the best one, right? So not the best answer. Planned vaginal birth, blood, no, not planned vaginal birth. I have B and D. Emergency cesarean section. Yes, it's correct. But what? Look, viral swab for PCR and the cesarean section. Now I know which one is the best. I have two correct answer. Choose the best. Right? You send it to the lab, my dear. They will do their whatever you want. Okay? For the rapid test or for the viral typing. It's not your problem now. Okay? Okay? I am dealing clinically with the case that this is a primary herpes. Now, right? Because the woman says this is the first time. So I have to deliver by cesarean section, right? But I will take the viral swab. This is for confirmation. I need to know what I'm dealing with. And you know, who is clever and tell me in the herpes nowadays, what is the test that we will request? Anybody? No. Don't go for PCR and wait for the result. Result will take time, my dear. Am I testing nowadays the sample for only herpes or other? Yes, it's others. Yes, nowadays, my dear friends, okay? Nowadays, I need the whole panel test. Yes, excellent, Dr. Sadia. Yes, exactly. Right? Yes, I need to test for the whole panel. Other causes of genital ulcers. They said even in the guideline that there is, okay, percentage of the ulcers found to be caused by what? You know what? Not the herpes simplex. Caused by the varicella. But it appeared like non-typical presentation of syphilis or varicella can give the clinical presentation of herpes. Right? What other organisms that can cause a clinical picture like herpes? Anybody knows? Yes, we said varicella, we said syphilis. Any other things? Anything? Mpox virus. Yes. Mpox virus. Yes, exactly. right? Why? Because it can also cause a papular or blister type eruptions and maybe now enter for the differential diagnosis, right? So herpes zoster enter now in the differential diagnosis. Syphilis enter now for the differential diagnosis. Yes. Yes. Okay. Okay. However, all the samples or all the patients, when you think that they have herpes, need to be screened for other sexually transmitted disease, like routinely chlamydia, gonorrhea, lymphgranuloma, right? But remember the panel test now. Okay, it's in the guideline update, virus detection and typing. It says that the PCR would include the specific type of herpes, the varicella zoster as well, treponema pallidum for syphilis, mpox, okay, depending on the risk, and lymphgranuloma PCR also can be considered, okay? Okay, be careful. Whenever there is new update, be careful. Okay, so look, my friend, this is a very easy question. A 23-year-old present at 38 weeks with spontaneous rupture of membrane 2 hours earlier. She complained of vulval pain on examination, clinical evidence of genital herpes, the cervix 2 cm long and osseous closed with clear liquor draining, no history of previous genital herpes. If vaginal delivery occur, what is the risk of neonatal herpes? 41%. 41%. Yes, it's in the guideline clearly 41%, right? So if it is 41%, you would choose 30 to 40 or 40 to 50? This is a recurrent, Dr. Ala. Okay, I would like to go for the higher, okay, for the higher percentage. If I have option of 40 only, I will go for the 40. Yes. Okay. So now, my friends, very important for the recurrent, what is the number? Recurrent is easy. Recurrent is easy, right? 0 to 3. Excellent. Okay. So here, my friends, I have the big topic of HIV. 32-year-old woman presenting a spontaneous labor at 40 weeks of gestation based on the late ultrasound scan. She had moved to the UK weeks earlier, and the result of booking blood test just been available. She's found to be HIV positive, and the viral load is unknown. So I have viral load unknown, and she's positive, did not receive anything. Okay? So what you are going to give to load the baby with other antiretroviral drugs? So if you have in the HIV is a big topic, right? Yes, of course. A woman presented in labor, and this woman in labor, right? She did not receive a prophylaxis. She did not receive, sorry, treatment, just diagnosed. Okay? So what are you going to do? Or what are you going to give? In preterm, there is a special consideration. Yes, for the mother, you will give the tenofovir. Is the question about mother? About protection of the mother or the baby? Yes, okay. Which medication is helpful to be given to a woman if she had a preterm delivery? Which medication can be given to the baby of a woman if she had preterm delivery? Post-exposure prophylaxis of the neonate. Now I'm not speaking about the IV zidovudine for the mother.
As a baby is high risk in this case, so we will not give the zidovudine, which is the normally given in the low risk or very low risk baby.
Okay, so what you will give the high risk baby, my dear? Anybody knows? Anything that I would consider for a preterm labor, for a preterm baby? This baby can take oral? The 28 weeks, this baby can take oral? Okay, so which medication can be given to the baby? My friends, my dear friends, where is group A of the MRCG part 2? Nobody's attending from group A? Yes, yes, I like the group A. Okay? You have to remember, okay? Allah, mashallah. Okay, so somebody is saying that I will give the zidovudine. Guys, why did he give you the age is 28 weeks? Why he give you the age is 28 weeks? What is the reason behind that? Yes, my dear, you are giving the correct combination, but only in one case. You know, what is this correct combination in this case? In term. Now I wanted a preterm. This is the full screen, Dr. Nabila. Can you see anything? Can you see anything on the screen or you can't see it? Anybody? Can you see the screen? Okay, yes, it's there. Maybe, sorry, maybe slow internet. Yes, this is the thing that you need to consider in the preterm because he told you preterm, correct? Once he told you preterm, means what? Means that he want to ask you about the special precautions or the special drug for the preterm baby, right? So what I will consider for a preterm baby, I would consider for the preterm baby the double dose of the tenofovir. count as a risk, my dear. Look, guys, I would say something, okay? But you just allow me to say it and we are friends, okay? Right? Recording. Dear friends, can you see the screen? Okay, so this is a screenshot from the guideline, okay? So I'm sorry that I had to stop the recording while I'm searching for that part in the guidelines, so the recording will not be actually corrupted. So here, my friends, in that part of the guideline, and this is page 44 from the guideline itself, if you want to go through it. Okay, so the cases where they come in labor, right, and they are not treated, they need a protection, correct? So what protection do you know? Most of you, my friends, would remember the IV ZVD, right? This is most of you would know this, correct? So if anybody remember the IV ZVD, they would just tick it in the question in the exam. But this is not, okay, the EMQs or the tricky questions comes. Actually, in the exam, they would like to twist a little bit, okay? So in the guideline says women are not already on CRT, what to start, okay? So the women who have the not on the CRT will not need only IV zidovudine. We can give her, okay, the very famous medication like the nevarapine, correct? Correct, okay? And especially the stat dose, the single dose of nevarapine as the first thing, right? Regardless of the CD4 count. And we would give this lady the intravenous zidovudine. Should be given or administered for the duration of the labor and the delivery, right? Okay. Following a loading dose of 2 mg per kg for 1 hour, the maintenance dose will be 1 mg per kg for 1 hour infused until the cord is clamped. So the whole duration of labor. Okay? Okay. So they found that the peripartum zidovudine infusion, blah, blah, blah. This is further reduced the transmission in women on even CRT, okay? And those who are not on CRT, both will benefit from the IV zidovudine. Okay, that's good. But what is the consideration for preterm labor? So in the preterm labor, the consideration that if the infant is unlikely to be able to absorb oral medication, consider the addition, okay, of the double dose tenofovir, okay, to the treatment described in recommendation 643. This is the up, okay? This is a recommendation. This is that we said. Why? Because it's a preterm, okay? To further load the infant, okay? So look, this is what came in the guideline, okay? Everybody, please listen. Why? Because the question came and says what? I told you the guideline is like puzzle game, okay? Pieces and parts will put it together. And this exam, the RTUG exam, is all about the words, okay? And I'll call it a game of words, right? Okay, so here, what is the question says? This labor at 28 weeks. So this is preterm or not preterm? Preterm. Good for preterm deliveries. Okay. And the lady here not treated. She has been found to be HIV positive and the viral load is unknown. So which part in the guideline I'm searching in? Am I searching now in the neonatal post-exposure prophylaxis or in patient presented in labor untreated? Which part in the guideline you are searching in? Which part in the guideline? In the neonatal post-exposure prophylaxis or in the patient attended in labor not treated? Attended in labor, not treated. So read this part, okay? You will find that the question also says what you will use to load the baby with other antiretroviral drugs. So is the question clear and easy now what he's asking to? Is it clear now? Okay. Back again. This is the question and this is the guideline. Okay. So I can see that he just, you know what? He designed the question. He tailed the question. He actually invented a question to check this part, knowledge of the 0.644 in the guideline. Okay? So 644 here, this is says in preterm labor, if the infant is unlikely to be able to absorb oral medication, considered in the addition of double dose tenofovir to the treatment described in recommendation to further load the infant. How many common words being used between the question and the paragraph in the guideline? How many questions are common between the paragraph in the guideline, 0.644, these books, and the question? My friends, how many words are common? Almost the same statement. Excellent, Dr. Sadia. Dr. Sadia, you are the queen of the day. I like all your comments today. Well done. Everybody clap to Dr. Sadia. Clap, clap. Really, mashallah. Yes, you are. Okay. So at 28 weeks, this is a preterm. What medication used to load the baby? Same as the guideline with other antiretroviral drugs, right? So same words, almost the same words in the guideline, correct? Yes. So now somebody choose, almost all of you choose the IV zidovudine. Guys, for God's sake, not all the cases are the same, right? Already told you what we will do in addition to load the baby with other retroviral. IV zidovudine is the base backbone of the medication, right? So the lady should have received everything else, but for the preterm, that's why he designed this question. She's at 28.
Yeah.
For the preterm, I added the double dose tenofovir. You got the point?
Yes,
And
madam, I have a question. Can I ask?
yes, you want to kill me with this question. Yes, I know your question. Tell me. Tell me. Tell me. Tell me. Tell me. Tell me. Yes. Yes, Dr. Alia, I'm just joking with you. Dr. Alia, please ask the question. Okay, I'm so sorry. I'm so sorry. Please.
Yes, I just want to ask that if this patient is already, mother is already on treatment and
Yes.
patient came with preterm labor, then what will be the management option?
You will manage her, my dear, according to her status, okay? So if she is a preterm lady and she is in labor, in normal labor, like means that she is a candidate of normal labor, okay? And preterm, you still add the medication, the double dose, the tenofovir, okay? If this lady, she is for cesarean section, for example, okay? Then she will have her IV everything, okay? So according to the plan of the lady, each case individualized. Okay, dear? Thank you very much, my dear, for asking. And please don't feel like, I'm so sorry if you feel bad. Okay, so open your mic, Dr. Alia. Please. I don't mind if you have a baby around or anything, it's fine. Hello, Dr. Alia.
Yes, yes, madam.
Okay, okay. Please tell me, don't feel bad. You don't want to tell me? You don't want to forgive me? I pick you, Dr. Alia. Please forgive me. Oh, guys, she doesn't want to forgive me. Dr. Alia, Dr. Alia, please don't. Don't feel bad. Okay. The voice is not clear. Okay, so I'm sorry, guys. She forgive me. Okay, but the voice is not clear. Alhamdulillah. I love you. Thank you very much, my dear. Okay, so look, my friends. Okay, now we will do this one. Okay, the one of the preterm labor for the woman who may come in labor while untreated. We know for this one who is not treated, you will give the stat dose of nevirapine, and this is would be the 1B evidence. This is very high evidence. You will commence the oral zidovudine and lamivudine. You will give the raltegravir. The woman will receive the intravenous zidovudine for the duration of the labor until the cord clamp. Okay, and we also will follow the PEEP or the high risk neonatal management for the baby after delivery. And then if it is a preterm labor, in addition to all of this list, you will add double dose of that tenofovir. Clear, everyone? Thank you very much, Dr. Kamla. This is Jazakallah khairan, my dear. Okay, good point? Good point. Okay, so I will feel satisfied, very satisfied, alhamdulillah, okay, if we revise together, my friends, the post-exposure prophylaxis of the neonate. Why? Because it comes in the exam and because it's not a common topic for a candidate to revise. Many of the candidates, to be honest, they miss this part in their study until they discuss the recalls, and with the discussion of the recall, they discover, oh my God, this part is important. Okay, so let's study it. Otherwise, maybe some people will go to the exam without ever notice or realize that this is important. Okay, so let's go through the neonatal part, okay, here for the neonatal management and explain it to you guys. And inshallah, it will help you. And hopefully that it will come as a question in the exam, because if it did, it will be very easy to answer. No actually doubt in this part. So yeah, I wish that they give you the HIV questions from this part because it's easy, really. Okay, it's both preterm or term, my dear, and we will see here. It's according to the criteria, Dr. Nora. Criteria applied. What are the criteria, my dears? There is a very clear criteria for the post-exposure prophylaxis in HIV for the neonate. One says, okay, that 2 weeks zidovudine monotherapy will be given for a very low risk infant who is considered as a very low risk infant. This is infant first term. Okay, we are speaking here in the very low risk about term. Okay, this is a lady, his mother. She got the combined CART for longer than 10 weeks. So she started in a good, like for example, in a good timing in the start of the second trimester. She completed her pregnancy. She was not she was taking all the doses. Okay, and this is appropriate. Good. At least 10 weeks is required of the combined CART. And two documented maternal HIV viral loads. 2 documented maternal HIV viral load less than 50. Means that not only one test, no. That the woman during the follow-up of her pregnancy, I found that, for example, at the 30 weeks, she was less than 50. When I repeated again at 36 weeks, I found that it was also, okay, negative, less than 50. So I have 2 samples less than 50. 3 will remind you of the 36 weeks. Okay, this is confirmed maternal viral load less than 50 at or after 36 weeks. And the 2 is not the same as 3. Okay, friends? So I have the woman received the CRT for longer than 10 weeks. This is the number 1. 10 will remind you of 1. 1, 1. Okay? 2 is 2 documented maternal HIV viral load less than 50 during pregnancy, at least 4 weeks apart. So this is 2. 3, maternal HIV viral load less than 50 at or after 36 weeks apart. So remember 3 with 36. 36. Clear, my friend? Okay. So this baby, if the mother fulfill all these criteria, this baby will receive what? Will receive 2 weeks of zidovudine monotherapy. Okay? Okay. Now I will go to the other risk group. What is the other risk group? Other risk group is the low risk infant. Low risk infant is a baby still low risk, but not very low. Means that one of the criteria above is missed. Let's see how. This is in the criteria above, okay, are not fulfilled, but maternal HIV load is less than 50 at or after 36 weeks. Okay, so maybe, for example, got 1 documented maternal HIV less than 50. Or maybe the mother received the CART 10 weeks or maybe, okay? But must, okay, that the viral load at the 36 weeks was less than 50 to consider it as a low risk. Or if the infant born prematurity. So here it's for preterm labor. So PEEP for preterm labor can be a low risk? Yes, let's see. Okay? Most recent viral load is less than 50. Means that, I'll tell you guys, when we say 4 and above, okay, that, for example, the mother, she received the treatment for more than 10 weeks. So 1 criteria is okay. And 2 documented maternal HIV viral load actually came as less than 50, 4 weeks apart. This is okay. So this baby who is low risk have 1 and 2. But, okay, at 33 weeks, the mother delivered. So now this baby missed which criteria? Number 1 or 2 or 3? Number 3. So if the baby missed one of the criteria above, okay, the baby is considered the low risk. If mother did not receive treatment and came in preterm labor for baby post-exposure will be high risk. No. My dear. Will be in high risk? Yes, will be in the high risk, okay? But we'll say, Dr. Nazia, that for the cases who's considered low risk or very low risk, it's a must that the mother, okay, have low viral load in the last test, less than 50, okay? Means that she was having treatment, correct? Okay, so the high HIV high risk. Yes, we said for the low risk, 4 weeks, low risk, 4 weeks of monotherapy. 4 weeks of monotherapy. In the high risk, I don't use monotherapy. In the high risk, I use combined post-exposure prophylaxis. Okay? And this will be 4. Look now with me. Use combination PEEP if maternal HIV viral load is known to be or likely more than 50 on the day of birth. Actually, those cases, we advise them to have cesarean, correct? But maybe for any reason, she wanted to go for a vaginal delivery. If uncertainty about the recent maternal adherence, so you are not sure if the mother was adherent to her medication or not, or if viral load not known, like the case who came in labor and did not receive treatment, and okay, in this case, you give her all this panel of protection and okay, will consider her untreated in labor, right? So her baby is at high risk. Her baby after delivered, okay, will receive 4 weeks, okay, of combined PEEP, combined post-exposure prophylaxis. Okay, friends? Neonatal PEEP be commenced as soon as possible after birth and at least within 4 hours. In the context of known maternal resistant to zidovudine, because there are some cases resistant to zidovudine with very low risk or low risk, zidovudine immunotherapy will be recommended, is still recommended for infant. So even if the maternal resistance is there, but low risk, okay, still continue with the zidovudine to the baby. But if high risk, okay, and there is history of documented maternal zidovudine or nevirapine resistant, seek expert advice. So in the exam, for high risk infant and the mother have resistance, you seek advice. Okay, if the advice not immediately available, then you can give combination of zidovudine, lamivudine, and nevirapine, and this is the standard high risk post-exposure prophylaxis. Okay, friends? So today, my dear friends, today, you will notice that we discuss things maybe you missed during your study, but believe me, all appear in the exam before. So you take care of these tricky parts. You study those algorithms that we sent to you today in the group. If you need other resources, please, okay, mention Dr. Nada in the group and inshallah, she will provide the resources to you. I need you to go back to the source, not the whole source. I don't want you today to open the whole 117 pages of the HIV, okay? I need you to revise the tricky point in the HIV, the exam point of the HIV only, okay? You only revise those things or study those things that you missed or you think that it's conflicting or something. Otherwise, okay, in the other guidelines, take care of the herpes. Herpes is very important. No exam without herpes question, especially that there is update in the herpes, okay? Also, varicella, there was part in the update in the post-exposure prophylaxis of varicella. Don't forget the differential diagnosis of viral rash in the pregnancy, how to identify this is rubella, this is measles. Why? Because it came also before in the exam and you are aware of it, right? Have a look to the Zika virus, okay, algorithm. Have a look to the malaria, for example, okay? The drugs for the malaria, what is the important thing and all, okay? But mainly the big guidelines for the maternal infection if one of my friends did not study syphilis diagnosis is very important in MCQ, and it comes sometimes each exam or each other exam. Okay, so diagnostic test for syphilis is must. Group B streptococcus and its prevention is must. So the big guidelines that you need to go for it today. Okay, you go for the group B streptococcus. You go for the herpes in pregnancy. You go for the varicella in pregnancy. Very small and tiny guideline, and you can get most of the information from the algorithm. Zika, you study the algorithm and the point of the prevention, okay, or the travel advice, okay? That's the important part in the Zika. In the HIV, okay, and syphilis, you have to go to the point that came in the exam. Most important point again is about, in syphilis, diagnostic test. Treatment also came, but diagnostic test you have to understand. Treatment also came in the exams. And for HIV, most important part in the HIV management during labor for the woman who attended in labor while treated or not treated. Recommendation, this woman will go for cesarean section or this woman will go for vaginal delivery. Which drug to give during the labor? If this woman is not treated before, so what medication that I will give to protect during labor or reduce the viral transmission? Okay, if preterm, I will give double dose tenofovir. What about if the baby delivered? If the baby delivered, what is the post-exposure prophylaxis? Okay, for the baby, is the baby very high risk or high risk or low risk, sorry, or very low risk or high risk? So you differentiate this point, my friend, and you will be ready for whatever question comes in the exam in the maternal infection, inshallah. Okay, my friends. Inshallah, recording will be available, okay, to all of you, my dear friends. Thank you very much for your timing. And now it's not the end of the session. Now we will end the maternal infections, but we'll have a little break and then come to solve some questions on the teaching module. Okay, thank you very much.